Okay, thank you for inviting me here today. I previously did some collaborative work, which I'll show some of it with Alex around one of the substrates which we hope to use in a clinical trial in the first quarter of 2011. I want to talk about a project which is, has its own life almost now, which is the London Project to Cure Blindness, so no pressure on me. The beauty of the eye is the fact that it has a nice window on the front, which in terms of surgical and viewing of what's happening, both in the disease and in the surgical application of what I'll show you today, gives us an opportunity which is rare in surgery. So we can view the back of the eye, which is where this disease is, and I'll tell you more about the disease in a second. Most photographers curse and moan about the red eye. This is actually what we like because it gives us a picture of the back of the eye. That red reflection is the normal retina, the seeing part of the eye, the back of the eye. Amazingly, and again where actually this project has taken quite a lot of imagination and why it's now being funded by Pfizer, is actually the area in which we view the world to actually read, see, do your surgery. It's actually an area, probably no more than about 10% of that whole eye. And in fact, a smaller area known as the macula, and in fact an area known as the fovea, which is less than a millimetre. So if disease encroaches on this area, without doubt, we'll go to an ophthalmologist, hopefully at Moorfields. If disease is outside the macular region, you tend not to notice it that much, apart probably from, say, night vision. So less than 10% is what's crucial. What you want to keep, you want to be able to read, you want to be able to see loved ones, obviously. But that picture doesn't really do justice to the underlying biology. There are three layers. There's the retina, the neural part, the seeing part of the eye, which contains all the receptors which process light. But the main layer, which is affected in the disease I'm going to tell you about in a second, is the middle layer. It's a carpet of cells. It literally is an Axminster of cells. A single monolayer of cells called the retinal pigment epithelial, which support the seeing part of the eye, that normal retina, by presenting it with nutrients, by getting rid of debris, by taking away heat, and also involved in the light cycle as well. And then right at the back of the eye, you have this huge blood supply, the corollary, which acts almost like a heat sink. So that middle layer is very metabolically active, creates a lot of heat. So that middle layer is crucial to the survival of the normal retina. So the disease I want to talk to you about, age-related macular degeneration. Typically patients will come into the clinic with the inability to either read text, or text is missing, or in some way skewed or distorted. We can do some very simple tests where just literally putting a grid in front of them, you can see, or the patients will report these types of distortions and greying out, as seen here in this, what I call Amsler grids. You get these distortions and greying out. And that's because there's a one-to-one association of visual space onto that macular region. So what you should see is very straight lines. So in this case we have straight lines, in this case we have distortions. If these two look the same, then you may already have a bit of retinal damage, okay? Because it is, you can see this in aging, or retinal detachment. I was lying to you. Hopefully, you will now see a grid. If you did see distortions in this, then you do need to go to Moorfields. Okay, so typically an AMD patient will see these types of distortions all greying out. What's happening? Again, because we've got that nice window on the front, we can take gorgeous, exquisite pictures at a resolution people would wish for in fMRI. We can take lovely pictures using very, very cost-effective pieces of equipment, which give very clear pictures of the back of the eye. So this bright spot is the optic nerve end, where all the information leaves the eye, goes to the brain. The pigmented area is the macula. And on the left you see nice pictures, hopefully we see these for the majority of our lives, With age-related macular degeneration, that central vision starts to go and distorts. And in fact, this doesn't do justice, really. The peripheral vision is a lot worse than you see here. This peripheral vision is definitely a lot worse. Two forms of age-related macular degeneration. Typically, the first called dry. You get these fatty deposits over that macula, over that central visual area, and it pushes the top layer, the neural retina, away from that middle layer its support. And because of that, the neural layer starts to degenerate and die. 90% of patients suffer from this form. No treatment at all, other than looking basically at lifestyle issues, specifically things like smoking. 10% of cases are the wet form. Again, you get these fatty deposits, but you get major bleed in this case. And that's because that blood supply at the back, the choroid, pushes vessels through the middle layer, which results in bleeds then between the neuroretinal seeing layer and the middle layer, pushing it away again from its support. So, just to get a bit of anatomy, so this carpet of cells, it's the RPE, the retinal pigment epithelium. For some reason, as yet, we don't really know why. There's many possibilities which are in investigation, start to degenerate and die. As a consequence of the disease there, the neuroretina no longer has its support, and that's why a person goes blind. So, back as far as 1998, we considered, well, is there any way we can replace the dying RPE? And in fact, there was one surgical treatment which we trialled at Moorfields, which was to translocate the whole retina. Can we actually lift that top layer of neural retina and move it away from the diseased RPE? So rotate the RPE about 30 degrees away from the disease onto non-diseased RPE. I'll just show you that operation now. So this is where you lift the whole retina off and you twist it away from the disease and then push it back down. Operation takes about 3 hours. It involves a further 2 operations, and because you have to rotate the whole eye the other way, otherwise you'd have the patient standing on the head. And then you have to fill the back of the eye with heavy oil to push the neural retina back into the back of the eye. You have to come back 6 weeks later to remove that heavy oil. This is Margaret, who actually went through an operation. She suffered from wet AMD at the time. At the time of her operation, there was no treatments for wet AMD. Now there's the anti-allergenics, which are successfully